Welcome everyone to this Lunch and Learn webinar on structured education. I am Candice Ward, the CDEP lead and diabetes educator, and I'm your host today. And I'd like to then hand over today's session to Sarah Kelly. She will introduce herself and take us forward. But just one more word, please keep your cameras off and your mics on mute. Thank you very much, and I hope you have a lovely session. Sarah, can you take over?
Thank you, Candice. Hello to everyone who's joined. Just before I dive into the content of the slides, I just wanted to introduce myself. So, as mentioned, I'm Sarah Kelly. I work in the National Diabetes Programme at NHS England, and my primary role is to kind of oversee the implementation of digital structured education programmes that NHS England have commissioned. But I also have a keen interest in supporting regions and ICBs kind of more generally with improving access to structured education. So with that in mind, these slides cover kind of the general structured education picture, kind of, you know, what we know at national level. So they are caveated with kind of if you have questions that are specific to your locality, I'll try my best to answer them here, but if it's a question for your local commissioner, we'll try and facilitate an answer offline. We can kind of connect you in with those people. So Candice is driving the slides for me, so I will do a Chris Whitty as we go through. So just making a start, the sessions of this objective are to support referrers to empower people living with diabetes to attend structured education, discuss the barriers to attendance and methods of overcoming these barriers informed by evidence and knowledge from colleagues in the system, and finally increase the awareness of the types of structured education currently available to allow referrers to promote patient choice. Next slide, please. We wanted to cover the purpose of structured education because there's sometimes a bit of confusion around what structured education is. We know that diabetes is a long-term condition, and I think there's some research done by Diabetes UK that shows kind of patients spend, you know, maybe 3 hours a year with a healthcare professional, and then for the rest of the year they manage their diabetes themselves, and managing it, of course, is complex, and there are multi-factors to consider in kind of good diabetes management. So the purpose of structured education is therefore to provide individuals with the knowledge, skills, confidence to better manage diabetes as a whole, which of course includes kind of eating well, being physically active, maintaining a healthy weight, but it's also about achieving HbA1c targets and taking your medication, foot care, eye care, emotional well-being, and more. And of course, good self-management kind of reduces the risk of complications. Next slide, please. So therefore, NICE recommends that structured education should be offered soon after diagnosis, at annual review, and to family members and carers if appropriate. I think all referrers will be on board with offering structured education, you know, at diagnosis, but equally important is offering it kind of periodically after that, whether that be at, you know, annual review or through another method. Because people who kind of don't take up the offer in the first 12 months may come to find that they want structured education at a later date because of a medical event or changes in attitudes to diabetes generally. And refresher courses for those who have already kind of attended structured education just allows them to, you know, have an opportunity to reinforce some of those key messages around long-term management of the condition. Next slide, please. So the picture across England informed by the National Diabetes Audit shows that despite GP referral rates being high, service uptake is low. Around 10% of people with diabetes are recorded as taking up structured education. We do know that there are some challenges around recorded attendance in terms of coding at practice level, but even when allowing for kind of coding challenges, it's estimated that about 15 to 30% attend. So, you know, room for improvement, I guess. Next slide, please. So what are the barriers to attending structured education that contributes to the low uptake? Next slide, please. To inform the conversation, we're looking at two pieces of research. A study carried out last year in the southwest of England interviewed adults living with type 2 diabetes who declined their invitation to attend a self-management programme. Next slide, please. And what the study found was it reported a number of barriers to attending. They were categorised into two themes, one being a lack of perceived need of structured education, such as kind of self-efficacy to manage diabetes or low prioritisation of the condition, and also limited knowledge of structured education itself. And the second barrier was around practical kind of attendance to the sessions. So that included scheduling issues and transportation issues as well. Next slide, please. And the outcomes from this research paper reinforces some findings from a systematic review looking at international evidence on the same topic in adults with both type 1 and type 2 diabetes. Again, the research found two similar themes: perception of structured education and practical reasons for not attending. And in the next slides, we'll look at some themes in a bit more detail with kind of suggested solutions. Next slide, please. So barrier number one, self-efficacy to manage diabetes. There was a general feeling from participants that they didn't need to attend an education programme. They identified that they already felt well informed about diabetes and knew how to manage it. And some said that due to improvements in things like blood glucose or cholesterol, they felt they didn't need to attend, or that they were receiving adequate support from their healthcare professional team. And then another reported factor that contributed to this barrier was that some participants, healthcare professionals, gave the impression that their condition wasn't harmful, so using words like mild or marginal, and therefore kind of felt that structured education wasn't needed. And I think in response to this kind of barrier as a whole, we know that, you know, kind of no matter how well informed an individual is, their diabetes knowledge or kind of self-management skills, they're unlikely to be perfect, and that good diabetes self-management, you know, requires that kind of ongoing commitment. So in many cases, there will be a benefit to attending structured education. And some of the ways that these kind of particular barriers can be overcome is share again with participants how structured education supports good diabetes self-management, so the message is clear. Encourage patients who already have a baseline of knowledge or have attended a programme in the past to try an online version of structured education. And that's so they can access key information and advice, you know, kind of as and when they need it, and address gaps in their knowledge. And then avoid using language that lessens the seriousness of diabetes, such as kind of marginal or mild, and instead communicate that it's a condition that needs to be managed. You know, even if the diabetes appears kind of marginal at the time of diagnosis, I guess the message shouldn't be, let's wait until, you know, it gets worse to take action. Instead, it should be, let's take action now to keep you well for longer. And these points around communication kind of apply, you know, to verbal comms in some places, but also written communications as well. So thinking about kind of referral letters to patients and information that's available in healthcare settings too. Next slide, please. Also identified by the research was that structured education was less likely to be attended by those who did not prioritise their condition. So this was commonly reported by people with comorbidities who kind of, you know, felt that diabetes was just another thing. Some of the participants described how they avoided their condition, so for example by denying the diagnosis, and also the research found that some held fatalistic attitudes, so felt like they, you know, kind of outcomes of diabetes are out of their control, or they're kind of powerless to change. So In overcoming these barriers, communication around structured education should reiterate how diabetes self-management can prevent further feelings of unwell. That might be a key selling point to those with kind of comorbidities or fatalistic views. And then secondly, low prioritisation as a barrier stresses the importance of offering a referral on an annual basis. That gives people opportunity to take up the offer at a time that, you know, kind of suits their journey. Or more specifically, you know, when they have kind of the space to prioritise diabetes. Next slide, please. So the final barrier identified as part of perceived need was limited knowledge of structured education itself. The research suggested patients didn't attend structured education because they had limited information around content of the sessions, reasons for their referral, or the personal benefits of attending, which then prevented them from making a decision on whether it would be worthwhile for them to attend. So the qualitative study by Coningsby found that patients could have been persuaded to attend if these gaps in knowledge were filled. And then there's some wider research that suggests when structured education is kind of sold to participants in a positive way, and attendance increases. So I recognise that individual healthcare professionals and referrers won't know all the details about all the structured education offers, but as the programmes will broadly cover the same topics and you know, aim for similar outcomes, having a general statement of information in your back pocket that kind of ticks these boxes will kind of help in overcoming the barrier. But it also might be the case that you practice or referral method uses written communication to inform patients about services. So reviewing that documentation and or include a kind of patient leaflet in there might also be a way of addressing this barrier. Next slide, please. So the second theme identified by the research papers was around kind of the practical barriers. Participants reported that the issues with the programme scheduling led to difficulties attending in-person sessions, and this was due to things like conflicting commitments around things like childcare and work. It was especially difficult for people who work shifts, who couldn't kind of commit to the sessions at the same time each week. And then some reported being, you know, unable or unwilling to give up free time to attend those sessions. So to eliminate issues around programme scheduling, digital structured education is now available across the whole of England. There are two nationally commissioned services, which is the My Type 1 Diabetes Programme and Healthy Living for People with Type 2 Diabetes. And these programmes are self-led, so participants can kind of, you know, log on when suits them, learn at a time and a pace that suits them to kind of access content that way. And there are other digital services that are commissioned locally. So I think Bertie Online for Type 1 and My Desmond is the Type 2 structured education service that's also digital, and that's just to name a few. But the idea obviously is so that patients can kind of log in when it's convenient to them, rather than kind of having to schedule attendance with a, you know, to a service or with a health coach. Next slide, please. And finally, the other practical barrier identified was issues with transportation. So this was both in relation to difficulties travelling due to reliance on public transport and difficulties travelling due to mobility restrictions. And the qualitative study reported that this was kind of particularly true in those with comorbidities who might rely on a carer or a driver to get around. So the obvious solution to this barrier is to kind of offer the service in another format. Your local ICB may commission a health coach-led structured education service that is kind of delivered virtually and therefore doesn't require travel. And alternatively, the online self-led programmes, such as the previously mentioned nationally commissioned services, might also be suitable. But another possible solution to this would be offer places to family members and friends or carers who kind of support the individual so they can also attend. Next slide, please. Next slide. Lovely. So the third and final objective of the session was to just discuss the types of structured education currently available across England, and that's to enable those referring into structured education to promote patient choice and ensure people with diabetes are accessing, a service that fits their needs and lifestyle, which will hopefully then lead to an increased uptake. So the services that are available across England, it's important to note that structured education is commissioned locally at ICB level and has been for a number of years. This allows ICBs to implement the services that meet the needs of their local population. And then at national level, we know that all ICBs commission face-to-face services. And for most, the coverage of the face-to-face service is ICB-wide. And then in addition to that, some ICBs also commission their own digital service as well. Next slide, please. So under the long-term plan commitments, NHS England commissioned digitally structured education programmes to be available nationally. This was to reduce variation in access to online services, support patient choice, and increase attendance to structured education programmes. So in summary, that would mean at an ICB level, face-to-face education will be in place, as well as nationally commissioned digital services. And then for some ICBs, there'll be other digital or virtual services commissioned as well. So therefore, there's a kind of solid menu of options available to patients. Next slide, please. So on this slide, we've kind of outlined the features of each of the delivery models for structured education, and this hopefully distinguishes between benefits for each type of service. The face-to-face programmes are of course delivered in person, and the content is delivered by a health coach. Very often they're delivered in group settings, and the programme is delivered over the course of a day or maybe hourly sessions over a number of weeks. That will depend on the provider's delivery model. And I think what's great about the face-to-face programmes is that it gives the patient the opportunity to ask questions and receive direct support from a healthcare coach, and it facilitates some of that peer support as well. But the numbers on face-to-face programmes may be limited because of the human resource element that's required to deliver the interventions. And some people just kind of won't want to attend a group session, and then for others, the in-person sessions come with the kind of scheduling issues, as discussed in the slide set. So in response to that, there is also a hybrid approach that takes the benefits of the kind of delivery by a health coach, and it avoids some of those issues caused by kind of needing to be in person by delivering the sessions virtually. I think some providers will replicate the in-person delivery model and deliver it across Zoom, so there's kind of no changes. And some deliver the self-led learning content alongside access to a healthcare coach, which could be, you know, like a one-to-one phone call or a couple of group sessions or something. Again, that kind of varies by provider. And again, capacity may be limited due to the human resource element required to deliver it. And then the final delivery model is what we've referred to here as online, which is self-led learning using a service delivered through a web portal or an app. So the nationally commissioned services fit into this box. And because online is kind of self-led, it offers that total kind of flexibility and overcomes those issues around programme scheduling. Some online services offer peer support forums, and the delivery model is kind of unlikely to have any capacity issues. So that means kind of online services are suitable as a standalone offer, kind of delivering the same content, but it also can be used alongside or after attendance to health coach delivered sessions as part of that kind of ongoing support. But I think the key is that kind of no single delivery model is better than the other. I think each look to meet quite different needs, and there should be a menu of offers available to people with diabetes, but they, you know, will kind of have access to at least face-to-face and online services, as mentioned. Next slide, please. So it might be that you're hearing about the nationally commissioned services in detail for the first time. So we've included just a couple of slides to give an overview of the services and kind of how to refer. NHS England have commissioned 2 online services, as mentioned. We have Healthy Living for people with type 2 and the My Type 1 programme as well. Both of the services are available now, and these slides will be shared after, so you can access the URL direct from the slides, but participants can self-refer, and all they need is that web address to do so. The services are free to the ICB and of course the end user, and they're available across the whole of England, so every ICB can offer access to an online service. Next slide, please. So the Healthy Living programme supports patients by providing skills and knowledge in diabetes self-management with the aims that they'll increase their confidence in managing type 2, also improve their physical and emotional well-being and feel motivated to continue making healthy lifestyle choices. Other key strengths of the programme is that Healthy Living is evidence-based with a randomised control trial showing favourable outcomes in those who've used it. It's Kismet accredited, and referrals into the programme are eligible for QOF points, as well as having kind of the no capacity limits. Similarly, My Type 1 Diabetes looks to help participants understand more about type 1, increase confidence in managing it, and support them to set achievable goals for better self-care. The topics on the programme include things like carbohydrate counting, living with type 1 and diabetes technology, amongst other things. And another feature of the service is that it offers translation of key resources in up to 10 other languages. And again, no capacity limits. Next slide, please. We just wanted to include here some examples of other commissioned services. So some of the well-known providers that are commissioned at local level include Bertie and Bertie Online and Daphne for people with type 1. And for type 2, there is Desmond, and then the online version is My Desmond, as well as Expert Health. But this is just to name a few. I think, of course, there'll be kind of other providers available. And then in addition, you might have services delivered by trusts or community healthcare professionals that fit within the kind of structured education box. And hopefully you'll know who your providers are at local level. I imagine that the kind of referral routes are well established, but if not, this is something your local commissioner should be able to advise on. Next slide, please. So just wanted to summarise the key points that we'd like you to take away. Hopefully you're convinced that structured education is an important part of diabetes management and is an effective way of improving diabetes outcomes, as well as kind of reducing complications and therefore reducing costs to the NHS. What we can see from the evidence is that those people who are referring into structured education are big influencers of an individual's perception of the service and their kind of willingness to take up the offer. Evidence shows that uptake increases if communications around structured education is positive and enthusiastic, and also kind of makes clear that it's essential for their diabetes management. Next slide. So carrying on with the theme of communication, we know that language matters. It's important that kind of communications around structured education don't undermine the fact that it's a kind of a serious, long-term but manageable condition. And again, I think the points around communication apply both kind of verbally as well as to written communications like referral letters, patient information that might be available in healthcare settings. So when taking action around this point, just make sure to kind of consider all routes of communication. The slides encourage referrers to make best use of the commission services, both face-to-face and online, and we hope that you'll build online services into your referral pathways if not done so already. And finally, this webinar may have introduced you to the idea of online education. I know a lot of you will be familiar with it anyway, but I hope you'll agree that online is a great option for people who kind of can't or won't attend structured education in person, and obviously online can be used as a further offer of support following structured education attendance at a different type of service. Next slide, please. So just highlighting here where you can find some additional information. There are some kind of open access resources on NHS England's website to support referrals into the national services, as well as kind of full implementation support documents on future NHS. You can sign up to our bulletin for programme-wide updates every other month. And CDEP, of course, have got some great resources available. But for other queries, you know, do contact us on our email address. We are going to open the floor up for questions in just a moment, but equally, you know, do contact us on email too. Next slide, please. And then finally, just before we take questions, we just wanted to close on the objectives. So hopefully at the end of this session, we have provided information and resources so you can empower people living with diabetes to attend some form of structured education. Discuss the barriers to attendance and methods or solutions to overcoming those barriers. And finally, increase your awareness of the types of structured education currently available to support with the provision of choice. I think that's it then from the slides. Yes, so Candice, back over to you.
Absolutely. Thank you, Sarah. There have been some nice questions coming through on the chat that I will read out to you. But if you've got any questions in the audience, please add them to the chat. We'll try and get to all of them within the next few minutes before the session closes. So the first question I've got for you, Sarah, is somebody saying, sort of, as a healthcare professional, it's easier to sell an education program if you know what's going on in it. Is it possible that people can sign up for themselves to these sessions, or would you discourage that?
Yeah, I totally appreciate that. It's nice to know what's covered, you know, what the content reads like, that kind of thing. For the digital services, absolutely, we kind of welcome, you know, healthcare professionals to sign up. And I think there is an option when you fill in the registration page to just toggle to say that you're a healthcare professional. I think you experience the programme as a patient would. So, for example, Healthy Living, a structured education element means that you will unlock content as you go, so you kind of experience the programme in the same way. And I know that the other providers are kind of, you know, largely supportive of you kind of accessing their content as well. The other digital services, I'm sure, will kind of grant access to their portals and that kind of thing. So yeah, we'll happily kind of share the self-referral route to the structured education services for the national, if that's the particular ones that you're interested in looking at. But equally, yeah, reach out to kind of locally commissioned providers, and I'm sure that they'll support you to access that so you can sell it better to patients. Absolutely.
And from a referrer point of view, would you prefer a certain person or a certain sort of the diabetes lead to be doing the referral, or can wider healthcare professionals working sort of across stroke or cardiovascular or refer people with diabetes into the appropriate services or education?
Yeah, so I think kind of primary care level, there's a recommendation from NICE around, you know, as part of diabetes care, people should be referred on to structured education. So I think they say at diagnosis and kind of annually. So yeah, anybody kind of within primary care who can refer into the services can and should. And then I think what we kind of envisioned for the nationally commissioned services with the self-referral route is that we would be able to implement it in other areas of the service where patients might be. So we're doing a bit of work with our regions to see if we can put the services within kind of secondary care and that kind of thing. And hopefully I've answered the question, but I may have interpreted it incorrectly. In primary care level, kind of you know, it could be any kind of healthcare professional or, you know, social prescriber who can be signposting to the services. I think one of our sites in the east of England have done kind of a bulk referral approach. So that's kind of like getting a clinician to create a search and then identifying people on your diabetes registers and then sending them a text message to say that you're invited to, you know, sign up to this self-referral structured education program. So there's many kind of ways, and yeah, there's no kind of guidance from us in a sense of, you know, we want to see a certain healthcare professional referring. I think it's just who the patient is and whether the service is appropriate for them, and if so, then yeah, absolutely signpost them to the self-referral route.
Brilliant. And if somebody does sort of accept that invite and enrolls themselves, how do the practice know? What is that feedback to get the tick that person has been coded as completing structured education?
So I'm not sure how it works at local level with local providers. That will kind of be agreed between your ICB commissioner and the provider. What we do with the national programs, obviously there's a self-referral route, and we've tried to make that as patient friendly as possible. So we don't ask for an NHS number, but we collect enough information to be able to kind of match them through a kind of nationally provided service. We can match them to their NHS number, and then we then can match them to their GP practice and share a report back to say this person has attended structured education. I think the level of information that we provide is alongside the structured education code, so that's attended, did not attend, and completed. But also we provide kind of like ICB level data packs for healthy living in particular. I'm not as familiar with the data that comes from the My Type 1 programme, but I can take that away as an action, and we'll include that in the FAQs when it goes back, so we can signpost you to where to find that. But healthy living in particular, we provide kind of data packs that show you at ICB level, you know, right down to GP practice level, how many patients you've got referred, and that kind of thing as well.
And who gets those referrals? Because that was one of the questions that somebody hadn't had any feedback yet from the Healthy Living program. How, you know, where would they be looking to get this data, and how often do you send that?
So the data packs come from us as national team monthly through regions and ICBs. So we can have a look into that for you just to make sure that you're linked in with the right person to see that data, because it is kind of shared on circulation at the minute. We don't kind of put it on a NHS Futures, for example. In terms of patient level data, you know, the outcome reporting for that, you know, Joe Blogs, for example, that'll go direct to the GP practice, if that answers the question.
Yeah. No, absolutely. And then reaching more sort of hard to reach groups, inequalities, language, any suggestions on how we access and provide structured education to those sort of previously disadvantaged or hard to reach groups?
Yeah, so the kind of supporting people with you know, diverse needs from ethnic minorities, I think is kind of twofold, in a sense of there's kind of the language barriers for some people living with diabetes, and then there's also kind of you know, accessing content that is culturally appropriate. So in terms of languages, I think they're from what we know at national, I know that there's a few ICBs kind of out there already that are commissioning services in other languages. So possibly want to pick up with local commissioners around delivering services in other languages. But the national services in particular, I know that the My Type 1 programme does provide some resources in translated languages. And then the Healthy Living has kind of the specific content, like a module with some content that's culturally adapted. So thinking about kind of, you know, food intake and dietary kind of requirements and that kind of thing, and just reflecting them on, you know, not necessarily a kind of, you know, European centric diet. It kind of is looking at the Eat Well plate in a bit more kind of, you know, focusing around, for example, a South Asian diet. So There's some stuff out there already, and I think we've also got a space on our NHS Futures page with some learning from other ICBs around what approaches they've taken to kind of meet, you know, diverse needs of diverse communities. So we can share that too.
That would be great. And then sort of there are various other programs sort of available, maybe, you know, weight loss as well as structured education. Do people have to do one or the other, or are they able to access both?
Yeah, so that's a good question. So I think there's a lot of programs available across the diabetes and obesity space, both kind of nationally and locally commissioned. If people are accessing a weight management service that's specifically focusing on weight management, such as, you know, the digital weight management service, they should also be offered structured education if it's appropriate. The two kind of programs are different in a sense of weight management will focus specifically on, you know, kind of the weight loss element, and structured education will cover a much broader kind of topic around diabetes care, thinking about, you know, taking your medicines, HbA1c targets, etc. So they do have quite distinctly different kind of aims, even though some of the kind of, you know, living well, weight loss, nutrition and physical exercise kind of information will overlap. NICE do recommend that structured education is offered as part of diabetes care, not necessarily weight management. That's not kind of, you know, appropriate for everyone with diabetes. You know, I think there's even kind of a cohort of people with type 2 diabetes who wouldn't meet weight management criteria. So it's just looking at it that from that lens, in a sense of, you know, weight management is kind of specific to the individual, but structured education should be available for everybody with diabetes.
Okay, thank you. And then if somebody's done structured education in the past and they want to redo it, is that possible to re-refer someone?
Yeah, I would double check with locally commissioned services around any eligibility criteria restrictions in that sense. I guess if there's some formats of delivery with capacity issues, then it might be that they discourage kind of re-referrals. But I think kind of generally speaking, in a sense of supporting people with diabetes, if they've accessed a service before and they want to kind of revisit any of the content, then they should be able to access a service. If it's a case of, you know, they can't attend a face-to-face because of any eligibility criteria restrictions, then absolutely, you know, the digital services should be made available for them. Yeah, I think kind of some of the way that we've positioned the national services in the past is that you can kind of dip in and out. So if you have a question that pops up, you know, when you're off to a wedding and you wanted to do some carb counting or something, then you can have that information in your pocket through the digital services. So yes, people should kind of have access to structured education if they want to be re-referred, and hopefully the national services support that in happening. I know it can be difficult with you know, if you've got local capacity issues, for example.
No, absolutely. I was kind of thinking maybe you were referred, you attended, but it wasn't the right time, or you weren't quite processed, you know, through the acceptance of diabetes or something, you were still struggling, and now you've moved on and it's a better time for you. When you talk about completing courses, is there sort of a special criteria that people have had to have done so much to say have completed the healthy living? What's that sort of metric?
Yeah, so we don't put any guidance out to the system in a sense of this is what you should, you know, set as a target for your local providers. Because I guess if you're attending in person, maybe it'll be 5 out of 6 sessions or something that they might count. So that will kind of be determined locally. What we do nationally for the digital services is we measure the engagement with the content up to 60%. The reason that we do 60% is because this is the kind of dose versus outcome measure that we've seen on other similar digital services, including the NHS DPP. So it's a kind of benchmark that we have lifted from other programs. We are kind of doing our own analytical review, so we might change that depending on, you know, what we find out in terms of dose versus outcomes for our own programme. But at the minute, once you've completed 60%, we can then code you as having attended structured education, and report that back to the system.
No, absolutely. And is there a way people can access maybe flyers or anything that they can give out to people about the national programs?
Yeah, absolutely. So we're on day 4, I think, of National Diabetes Week, very appropriate for our slides. So with that, we've got some promotional materials that we have shared on like a toolkit, but within that we've got some order forms, so you can order leaflets to your GP practice or to your ICB. So I think it includes about 100 patient leaflets, some business cards in there, so you can give those away, and posters for your waiting rooms and things like that. So we'll share those around, and please do order what you need.
Excellent. I think we've come towards the end of the session. I think I've captured all the questions so far. If we have missed a question, we will get in touch with you with an FAQ and get back to you. But please do note that we will be sending out an attendance certificate and a PDF summary of all the slides, as well as the recording will be able to be found on CDEP under webinars, and we will send you the link. So you will be able to have resources following this session and an FAQ. So thank you very much to Sarah for presenting today and answering those questions so beautifully. And thank you very much to everyone in the audience who has watched and contributed with those really insightful questions. I really appreciate your time today. But I'll draw this webinar to a close. So thank you again, Sarah. Thank you again, everyone else, and have a lovely rest of your day.